No disclosures. Case 1 is a fairly straightforward case. It's a 24-year-old woman who was sent for evaluation for possible coarct, and also the cardiologist said that she had mild aortic insufficiency, and he wasn't sure what her valve morphology was on echo. So even with a little misregistration, you can see that she certainly doesn't have a coarct, but if we turn her aorta, she does have very interesting aortic valve leaflet morphology. If we take a little closer look at that, she's one of those rare cases of a quadracuspid aortic valve in that she has a left cusp, a right cusp, 2 non-coronary cusps. She has mild valve leaflet thickening, failure of the leaflets to oppose during diastole, and only a very small aortic regurgitant area. This entity patients usually present with aortic insufficiency in the 5th to 6th decade. So that's a quick warm-up case. Second case, we have a 57-year-old male active athletic computer programmer. I thought that was an interesting description in his medical history. I was like, his fingers are athletic? What? I'm not sure. But anyway, he presented about 10 days earlier with classic symptoms of acute bacterial endocarditis. And it's amazing how sick these folks get. This guy all of a sudden had trouble walking, had a lot of balance issues, and he was basically having septic emboli to his brain. And his renal failure was not related to septic emboli. They actually thought that he had gotten dehydrated. But anyway, no real good risk factors. He failed 2 weeks of IV antibiotic therapy. And what does failed that mean? It means you start off with a small vegetation, a non-surgical vegetation less than a centimeter, with maybe some mild aortic insufficiency. And then despite appropriate antibiotic therapy, the vegetation almost tripled in size, and he had severe AI. So we see a fair number of these folks for pre-op coronary CT clearance because they don't want to put a catheter across the valve. They're a challenging patient group because I like to say they're quasi-stable. Not sure how stable each one's going to be. There's some urgency to get the scan done because there's an ongoing risk of another embolic event or of rapid destruction of the aortic valve and the consequences that happen with that. They often have severe aortic insufficiency and some degree of CHF. So you have to get the techs to trust the test bolus. A lot of times it'll be really delayed because not only do you have to overcome the backwash of unopacified blood from the ascending aorta, but also their EF is bad. I mean, I've had people take almost, my record was like 55 seconds to get contrast where it needed to be. They can have a wide impulse pressure, and what that means, the difference between their systolic and diastolic pressures, reflects their degree of aortic insufficiency. And so a lot of the things that we want to do to make beautiful coronary CT images, we may or may not be able to do in this patient population because they're too unstable. And find that the acute endocarditis patients are usually much sicker when they come to CT scan than the subacute one. That said, this guy was kind to me. He had pipes for coronary arteries and certainly had no obstructive coronary disease. We also get a good look at their vegetations when they come for CT, and he has a classic, we've seen this a couple of times in this conference, a multilobulated filling defect on the LV side of the aortic valve. When they had done his TEE, actually, they weren't sure if he had 1 or 2 vegetations. We could clearly see that he had 2 vegetations. You can send in the images and you can show how mobile this mass is, or you can go ahead and see your aortic regurgitant area. But that's not that big of a deal. What it's really important for us to do, because they know that information, is to actually really look at the aortic root itself. Look where the vegetation is and look at the surrounding structures. You want to look at that aortomitral curtain because an infection here can very easily cause problems with the mitral valve also. You want to look at the crista supraventricularis for if you have an infection involving the right coronary cusp, that it's not going into the RV or the PA. The non-coronary cusp infection can involve the intraatrial septum. So those are important information we need to really provide on these. This guy looked like he had a simple, just vegetations, no perivalvular abscess, pseudoaneurysm, or fistula. He was repaired with an aortic bioprosthesis and got an aortic root reconstruction. I have a healthy respect for people with endocarditis who have been bacteremic for a bit. They tend to seed other things. He did well for 3.5 months. And he came back with recurrent symptoms, said he felt the same way. We see his felt pledge. He had a non-contrast chest CT. I don't know why he got a non-contrast one in the ER, but that's what he got. Maybe his kidneys were still an issue. You see his felt plegid, but then you have a really tough time making out the anatomy between that aortic root and the pulmonary artery and the RV outflow tract, because he has this really complex kind of phlegmonous fluid collection interposed between the two, and he really has inflammatory changes going all the way around. He also has a loculated pericardial effusion with some dots of gas in it. Within 2 hours of the scan, this man was dead. He ruptured this into his RV outflow tract, and that was it. Case 3. We do a lot of PE house patients, or we do a lot of PE studies overnight, and I'm always badgering my residents to look at the heart, look at the heart, look at the heart. This was a lady. She was an in-house patient. She had a chest CT to rule out PE. We actually got an indication. A lot of times it just says rule out PE, but this one said persistent tachycardia. Reasonable overnight read. The study was really compromised. She was tachycardic. She couldn't breath hold. She had nothing central or segmental, and she looked like maybe she had some failure. Then we look, we're like, well, wait a second, she just had a CTA 12 hours earlier. No, she just had scalp views 12 hours earlier. She had gotten down to the scanner and she had become acutely dyspneic, dropped her SAT. She basically had flash pulmonary edema. And they took her to the CCU and they diuresed her for a bit. And then after about 7 hours of that, she basically had a transthoracic echo. And it was compared to one that they had 2 weeks earlier. And really the only significant finding they noticed was that she had much more severe AI than she had 2 weeks before, and nothing else was going on. Just want to draw your attention to this little defect here, which actually had flow in it, which, again, didn't really catch it on transthoracic echo. We also saw some other history on her. She was actually pretty complex. She had been transferred in with ARDS from pneumococcal pneumonia, bacteremia, and sepsis, and had some unhealthy lifestyle issues. So when we look at her CT, and we're going to hope this one works, that does, okay. So in fact, it is not the world's prettiest PE. There's gross motion on it. We have a large amount of pulsation artifact involving the aorta and the pulmonary artery. She clearly has pleural effusions, clearly has perihilar airspace disease, which was probably her pulmonary edema. But nothing lives in between the left atrium and the aorta. And if you look and you follow this little tubular collection, here, let's see if I can do this. Follow this little tubular collection. We see this collection interposed between the aorta and the LA. It wraps around. It actually takes the course of what you usually see for an anomalous circumflex, but there's her circumflex coming off her left main, reading through all the motion. You've got to read what you're given. And we see this collection. It looks like it goes towards the RV. So we were the first to suggest, we really think this lady's got endocarditis and has a paravalvular abscess. We had reconstructed her data very quickly to show the same thing. Then I actually went to lecture the medical students for 2 hours and told Friedrich she may come down for a cardiac CT if they can get her heart rate controlled, but we're hoping they'll just do a TEE on her. Well, what they did was they sent her down without heart rate control. I came back from lecture and Friedrich had these images for me. He said she had a heart rate of 104, but they said they're not going to get the TEE till later. Can you just scan her? So even through the world's most awful cardiac CT images, you can still see this collection, and you actually get the hint that there's a little squirt of contrast going into her RV. All right, I know you have to kind of take that with a grain of salt, but we did think that. She finally got her TEE done. Well, even on this TEE, on this one last image that's on there, here's this fluid collection that goes from, it's interposed between her left atrium, her aortic root. It comes around, it wraps around the aortic root. You could actually see her vegetation better on this than we could see on anything else. So she indeed had a paravalvular abscess and a pseudoaneurysm. And she actually had the fistula was to the RV. They thought on this TE that maybe the fistula was to the RA. So even with our horrible CTs, we had actually come up with the fact that she had the fistula to the RV. Here's another gentleman. He came in with classic signs, classic findings of subacute bacterial endocarditis, a more chronic presentation, more associated with joint aches, night sweats, and weight loss. He had classic risk factors of congenital bicuspid aortic valve, and he had had a root canal 6 months prior. He again failed IV therapy. He had ongoing ongoing positive blood cultures with strep viridans, had septic emboli to his brain, had 3+ AI. So his CT, I'm so happy it worked. So on his CT, we did, we did a much better job quality-wise for his coronary CT. And I know Travis showed you some similar cases, but the first thing we see on him is this very large pseudoaneurysm. that extended from what was a right cusp towards all the way over to almost the LAD. Is actually causing some mild mass effect on the region. It's hard to see what his valve morphology is. He has diffuse valve leaflet thickening. You're like, is that something that's a communication in there? But the other area I want to draw your attention to is, again, he has all of this infected aortic valve, but if you go to that aortomitral curtain, the communication between the anterior aspect of the mitral annulus, not the communication, but where they're joined, and the posterior aspect of the aortic annulus, you see that he has another fistula and he has thickening of this. We were able to clear his coronaries a little easier than the other folks. Here's his LAD, his RCA. Again, you get the ugly look at the valve. He was a bicuspid aortic valve, so it was kind of cute, almost like Pikachu, that he had a little coronary artery anomaly. He had absence of the left main and separate origin, the LAD and circumflex. But there's nothing cute about having your aortic valve leaflets look like Pac-Man. This is the big fistula extending from his right coronary cusp. The experience that I've had is anytime we find one of these good-sized pseudoaneurysms, it's amazing to me how quickly they actually go and rupture into adjacent structures. So he was operated on within 2 days. And by that time, the pseudoaneurysm had already developed a quarter-sized PA fistula. So that was pretty impressive. Here's his valve. It was totally destroyed. You really have a hard time recognizing it as a bicuspid aortic valve. But he got repaired. He got a mechanical valve. He got a pericardial bovine patch for his fistula, and he's done fine ever since. Again, some interesting issues come up when we're doing these endocarditis cases. The techs were localizing another lady who had just been transferred in with a known bicuspid aortic valve, acute endocarditis, and they said, we aren't sure we can see the left main. Fair enough. Do her test bolus, and you can see why they can't see her left main, because she has a big pseudoaneurysm coming off of her left cusp, and it actually was separate from her left main, her LAD, and her circumflex. And again, look at all of the phlegmonous change, inflammatory change around there. She's another one operated on within 5 hours of this study, had ruptured that into her RV. She did okay, though. So when we talk about endocarditis, remember that 50% of the time endocarditis occurs on the aortic valve. People can be coming in through the ER with some nonspecific symptoms, specifically if they have subacute endocarditis. Fuchsner showed a number of years ago that when you look at CCTA versus transthoracic echo, that for surgical lesions, those lesions a centimeter or greater, that CCTA is as good as TEE. And as good as TEE for perivalvular abscess detection, probably defines pseudoaneurysm extent better than TEE, and TEE, because it can do flow imaging, will show you small perforations better. We're going to change topics. Here's a 38-year-old guy. He's a very recent case. Just got his surgical specimen Thursday. 38-year-old guy showed up in cardiology clinic with symptoms of new onset CHF that had been gradually increasing over the past 2 months. Significant past history of an aortic coarct, status post-repair at age 4 years. He had been followed at our local children's hospital routinely, and then lost to follow-up about 10 years ago because he felt well, he just didn't want to go back. In clinic, his exam was notable for being tachycardic and having a prominent systolic ejection murmur with a late diastolic component. So he was basically booked for 3 studies at the same time, TEE, or we didn't do them at the same time, TEE, cardiac cath, and cardiac MR. Question, does he have a coarct-associated lesion? Does he have coronary artery disease causing his new onset CHF? Or does he have a recurrent coarct? And it's important to remember, even though coarctation, simple coarcts are considered surgically corrected lesions, we know from looking at the Boston Children's series that even uncomplicated coarcts have a significant incidence of associated valvular heart disease. So it's important to keep in mind. Plus, recurrent coarct or complications from the surgeries, we also have to keep an eye out for. So he had his TEE. And his TEE, I'm not showing the LV views, I'll show you that on MR. He had severe global hypokinesis, low EF. He had an uncertain aortic valve morphology. It looked like it was probably bicuspid with a big, heavy calcification. Both by continuity equation and by planimetry, his aortic valve area showed severe stenosis, yet he had a low flow, low gradient state. It's the paradox of someone having severe aortic stenosis whose LV has decompensated. Their pressure gradient isn't going to be that bad. He had his coronaries cleared on cath, and I'm not going to show you normal coronaries. He didn't have a recurrent coarct. We saw that, and we also showed that on MR. What's interesting on this to me is look how heavily calcified that valve is, and look how you don't see it moving at all. So that was pretty impressive. So he finally he got his cardiac MR, and we had concurrent findings with the TEE in that he had LV dilatation, severe dysfunction. You can see the heavily calcified valve. You can see the stenotic jet. But look at his axial image. And the question is, what's that? He also had no late gadolinium enhancement. And so we were questioning what the morphology of the aortic valve was. And people were arguing this is bicuspid, or we were also arguing we think it's something else. We think it's unicuspid. He actually was getting ready for this talk, and I was like, no, he looks like a unicusp. He looks better than the picture they have in Radiographics of the valve that goes with this. This is our guy versus the Radiographics thing. So they have a single commissure. They have this kind of horseshoe-shaped, just soft tissue. So the poor cath fellow presented him in cath conference and was kind of eaten alive by the pediatric guy. But we stood fast, and we told the surgeon, just give us pictures, so he did. Anyway, his unicuspid aortic valve is a very rare aortic valve anomaly. Patients usually have severe aortic stenosis, and they can end up with some AVR later on. It does have a strong association with aneurysmal dilatation of the ascending aorta. This is Thursday, hot off the presses. Here's his aortic valve in the OR. Doesn't even look like an aortic valve. Looks like silly putty with a little dot on it. Here's his path specimen. Unicuspid aortic valve. He has one commissure, and then he just has, this is all he has left, and it's a really nice correlation with that. And so this was long-standing severe aortic valve stenosis. And again, I'm sure when he was followed for years that they probably thought they were looking at a bicuspid valve on echo, causing LV failure. And it's interesting, so for severe aortic stenosis cases, that's one of the things that even if we saw delayed enhancement on his MR, they will still replace the valve, still think they're going to get better. Give them the opportunity to get better, because a lot of them will still improve even if they have some scarring. All right, this last case, one more odd one. 40-year-old, basically healthy, morbidly obese, and a smoker. Okay, so maybe not so healthy, who had a new murmur on physical exam. So she had an outpatient transthoracic echo done, and they read it out as she has a large thrombus like filling her RA. She has small thrombus on her MV, and they called her and they had her go to her local emergency department. Of course, her D-dimer was positive, and the first thing that people worried about was, does she have a PE? So she was transferred to our hospital. The cardiologist doing the TEE called me and said, can you please review her PE study? I need to know, does she or does she not have a PE? As well as all the other stuff I'm going to show you. So when we do her study, this is her outside CT, and she did not have a PE, but she has very interesting findings. Let me get this so I can catch it. Okay, there we go. So first you start seeing a big filling defect in the IVC, and it's not just mixing, because it's contiguous with this big round glob in the RA, which goes into the RV. Follow it down. It starts coiling up by the region of the moderator band, turns back on itself, follows the septum, comes back across the tricuspid valve. Hoo-hoo! She's got a patent foramen ovale. It's coming across. It then coils up in the LA. It's a little hard to see on this, and I had a million reconstructions, but I didn't want to show you the same thing in a million different planes. And you see it subtly going across the LV. If you don't buy it on that, whoops, let's see if we can get out of this now. You might have to advance me. There we go. Here's her TE. This is why my colleague panicked, and he goes, and she was coughing during this, and he was getting so nervous. She had these big tubular and globular looking things on both chambers, or all four chambers, RA, RV, LA, LV, and here you can see it in the patent foramen ovale. If we go to her next view, here it is in transit going across the patent foramen ovale. So it was fair to ask if this lady was having paradoxical PE or something like that in the world's biggest thrombus. They took her to the OR. When they went to induce anesthesia on her, she basically, because she probably dropped her systemic pressure, she all of a sudden acutely obstructed both all of her RV and all of her LV outflow, RV inflow and outflow. or at least across the tricuspid valve. And she actually had a pulseless electrical arrest. They did get her back, and she was fine. And this is the quote from my surgeon is, "This is the monster I pulled out of her heart in her IVC." This came back as an endometrial stromal tumor with smooth muscle differentiation, read out as either an atypical leiomyoma or smooth muscle tumor of uncertain malignant potential with intravascular intravenous leiomyomatosis. None of this, the big differential would be to differentiate this from an IVC sarcoma, but none of this was attached to anything. It was all free-floating. It wasn't attached in the heart or anything else. They had done, I'm sorry this is a CT venogram, but that's what they had asked for because they needed to put a filter in her to prevent any more of this from going up while they figured out what to do with her. So we just have images on a CT venogram showing her enlarged heterogeneous pelvis. It was very concerning that she had what looked like might be adenopathy in her pelvis. And she had an MR recently, and she doesn't have the typical appearance that we see for leiomyomas, but she has the typical appearance of what we see for this entity, in that they actually have a higher signal on T2. They drastically enhance, and you see all these tubular worming structures all over, because basically this is intravascular leiomyomatosis. And it's worth knowing as cardiac imagers, it is rare, but what happens is that it'll extend into the RA, and it's associated with fatal obstruction because it either can fill the RA or completely obstruct the tricuspid valve. It's the same entity that gives you benign metastasizing leiomyomas in the lungs. What's I think was very interesting is that the mean interval between hysterectomy for someone who's had leiomyomas and a diagnosis of IVL is 3 to 4 years. So if you can show that someone had a prior history of that, you should suspect it. Anyway, we have mainstays of diagnosis. They actually do very well. The treatment is total surgical excision. The tumors are hormonally responsive, but they do recur, so people do require surveillance imaging.